Hi, welcome back to your prescription for medication education. My name is Henry and I'm a pharmacist. And if you enjoy learning about medications, then I think this is the right channel for you. Today I'll be talking about aldosterone antagonists, so I'll go ahead and begin. I like to start off my videos with 5 questions. At the end of the video, I'll go ahead and provide the answers. So question number 1, a patient is taking spironolactone with food. Which of the following is the most accurate statement regarding this administration? A, food decreases bioavailability, requiring higher doses. B, food has no effect on absorption. C, food increases bioavailability, so consistency in administration is important. D, food delays absorption and reduces efficacy. Question number 2. A patient on spironolactone develops menstrual irregularities. Which of the following best explains this effect? A, selective blockade of mineralocorticoid receptors. B, increased aldosterone production. C, progesterone receptor agonist activity disrupting hormonal cycling. D, increased estrogen metabolism. Question number 3. A patient taking spironolactone develops breast tenderness and enlargement. Which of the following best differentiates eplerenone from spironolactone? A, eplerenone has greater mineralocorticoid receptor affinity. B, eplerenone has significantly less binding to androgen and progesterone receptors. C, eplerenone causes more hyperkalemia. D, eplerenone is not metabolized hepatically. Question number 4. A patient with heart failure on spironolactone has an eGFR decline from 55 to 38 after initiation. Potassium is 4.9 milliequivalents per liter. The patient is stable. Which of the following best describes this finding? A, definitive evidence of intrinsic renal damage. B, pseudo-worsening renal function due to hemodynamic changes. C, acute interstitial nephritis. Or D, spironolactone-induced nephrotoxicity requiring immediate discontinuation. And the last question, question number 5. Which of the following ECG findings is most predictive of serious adverse cardiac events in a patient with hyperkalemia? Is it A, peaked T waves, B, flattened P waves, C, prolonged QRS duration, or D, shortened QT interval? Let's begin with a quick and simple refresher on what aldosterone is. Aldosterone is the most important mineralocorticoid in the human body. Mineralocorticoids are steroid hormones derived from cholesterol. Aldosterone is synthesized exclusively in the zona glomerulosa of the adrenal cortex via a series of enzymatic reactions that I will not be covering here. Aldosterone primarily binds to the mineralocorticoid receptor. After binding, it increases the expression and activity of proteins involved in sodium reabsorption and potassium secretion. In the kidneys, it increases the activity of epithelial sodium channels on the apical membrane and increased sodium-potassium ATPase activity on the basolateral membrane. Aldosterone production is regulated mainly by angiotensin II and elevated extracellular potassium. Adrenocorticotropic hormone also plays a minor role in its production. Aldosterone's main purpose is to increase sodium reabsorption in the late distal tubules and collecting ducts, while increasing excretion of potassium and hydrogen ions. This means if we have an excess of aldosterone production, it can lead to sodium retention, volume expansion, and potentially hypokalemia and alkalosis. Aldosterone can also have other detrimental effects. In the heart, it can result in interstitial cardiac fibrosis, resulting in myocardial stiffness, decreasing systolic function, and increasing the risk for ventricular arrhythmias. Aldosterone can also increase insulin resistance and has pro-inflammatory effects. Aldosterone antagonists work by blocking the mineralocorticoid receptor, which is why they are also referred to as mineralocorticoid receptor antagonists. They compete with aldosterone for binding at mineralocorticoid receptors in aldosterone-sensitive tissues, especially in the distal convoluted tubules and collecting ducts. This results in increased sodium and water excretion while reducing potassium excretion. By antagonizing the mineralocorticoid receptor in the heart and the vasculature, these medications can help reduce inflammation, cardiac remodeling, and fibrosis. They can be categorized as steroidal or non-steroidal. Steroidal mineralocorticoid receptor antagonists include Jesus, spironolactone and eplerenone, while finerenone is a non-steroidal mineralocorticoid receptor antagonist. I won't cover finerenone in this video because it's not approved for hypertension. Spironolactone is more potent than eplerenone at lowering blood pressure on a milligram for milligram basis. Spironolactone has been shown to reduce office systolic blood pressure by approximately 13 to 20 millimeters and diastolic blood pressure by 6 to 9 millimeters of mercury compared to placebo. Adverse effects include hyperkalemia and worsening renal functions for both medications, but spironolactone is more likely to cause endocrine adverse effects such as gynecomastia in men and menstrual irregularities in women. Key warnings and precautions include electrolyte imbalances, patients undergoing adrenal vein catheterization, and use in women of childbearing age. Its contraindications include Addison disease and hyperkalemia. Its clinical uses include heart failure, hypertension, primary aldosteronism, and ascites due to cirrhosis. Spironolactone has been around since the 1960s and has two brand name formulations available. Aldactone, which is the oral tablet formulation, and Carospir, which is, I believe how you pronounce it, is a 25 milligram per 5 ml oral suspension. For hypertension, spironolactone is generally not used as a first-line medication. Its usual initial dose is 25 milligrams by mouth once a day, titrated monthly up to 100 milligrams daily. Advise the patient to either take it with or without food, but it's important to keep it consistent because when taking spironolactone with food, it increases its bioavailability. For patients with heart failure and renal dysfunction, it's generally avoided if the eGFR is less than 30. If spironolactone is used to treat hypertension in children, its initial dose is 1 milligram per kilogram per day, but data is limited in this population. An important and interesting side note is that Carospir, the oral suspension, is not milligram for milligram interchangeable with the tablets, as it produces 15 to 37% higher serum concentrations. Drug interactions include medications that increase potassium levels and colcintropin. Eplerenone was approved in 2002 and its brand name formulation is Inspra. It's available in 25 milligram and 50 milligram tablets. Its initial dose is 50 milligrams by mouth once a day and has a maximum recommended dose of 50 milligrams twice a day. Its use is contraindicated in patients with a creatinine clearance of less than 50. It is a CYP3A4 substrate which causes interactions with CYP3A4 inhibitors. Renal dysfunction can occur with aldosterone antagonists via multiple mechanisms, including impaired potassium excretion, volume depletion, and changes in intrarenal hemodynamics. These effects are dose-dependent and more common during the initial treatment and are considered reversible with drug withdrawal. Although mineralocorticoid receptor antagonists are weak diuretics, some patients experience more diuresis than expected when placed on a medication in this class, especially if they're on another type of diuretic. It's important to remember that volume depletion contributes to acute kidney injuries. What is important to take into consideration is that an early eGFR decline after starting an MRA does not necessarily mean structural kidney injury is occurring, but may be due to hemodynamic changes. Data from pooled analysis of RAILS and emphasis HF suggest that worsening renal function associated with mineralocorticoid receptor antagonist treatment may have different prognostic implications than the spontaneous renal decline. These studies show that even when patients' eGFR fell to less than 30 during therapy, patients still derive mortality benefit from continued treatment, but the risk for hyperkalemia increased substantially when compared with placebo. This is often referred to as pseudo-worsening renal function, similar to what occurs with ACE inhibitors and ARBs. A 2025 meta-analysis found that spironolactone was associated with an increased risk of kidney injury with a relative risk of 1.78, while eplerenone and finerenone did not show an increased risk. Essentially, what I'm trying to get at is that certain patients may benefit from continued treatment, but we shouldn't ignore the labs either. I'll finish up this slide with a reminder to not initiate mineralocorticoid receptor antagonists if the patient has an eGFR of less than 30 millimeters per minute or a serum potassium of 5 or higher. The American College of Cardiology recommends monitoring potassium and renal function at about 1 week, then 4 weeks, then every 6 months. Spironolactone causes gynecomastia and menstrual irregularities because it is a non-selective steroidal MRA that binds to androgen and progesterone receptors in addition to the mineralocorticoid receptor. In men, spironolactone competes with testosterone and dihydrotestosterone binding to androgen receptors in breast tissue, which block the normal inhibitory effect of breast development. It also decreases testosterone production in the gonads and adrenal glands. It inhibits 5-alpha reductase, which is responsible for converting testosterone to DHT. It increases sex hormone binding globulin, further reducing free testosterone. This culminates in a reduction in androgen production and blocked androgen action, creating a relative estrogen excess, which stimulates breast glandular tissue, causing gynecomastia. The effect is dose-dependent and usually reversible if recognized early. Spironolactone has agonist progesterone activity, which can disrupt normal hormonal cycling of the menstrual cycle. About 20 to 40% of women using spironolactone experience increased menstrual frequency and irregularities. The use of combined oral contraceptives can help regulate women's menstrual cycle if currently taking spironolactone. Eplerenone was specifically designed as a selective MRA to minimize binding to androgen and progesterone receptors. Compared to spironolactone, it has a 500-fold lower affinity for these receptors, which is why only about 0.5% of males develop gynecomastia compared to 9% with spironolactone. Addison's disease, also referred to as primary adrenal insufficiency, involves the destruction of the adrenal cortex. This results in deficiencies in both glucocorticoids and mineralocorticoids. The clinical manifestations include hyperkalemia, hyponatremia, hypotension, salt cravings, and volume depletion. These patients need mineralocorticoid replacement with fludrocortisone to restore sodium-potassium balance and maintain blood pressure. If a patient is placed on an MRA, then we are antagonizing the therapeutic effect of fludrocortisone at the mineralocorticoid receptor, essentially worsening sodium loss, hyperkalemia, hypotension, and volume depletion. Spironolactone is often used in young women for the treatment of acne, hirsutism, and polycystic ovary syndrome. It's important to review its potential impact on fetal development. Women of childbearing age taking spironolactone should be counseled to avoid pregnancy because of the potential risk for abnormal male fetal genital development due to anti-androgenic effects. Spironolactone crosses the placenta and may interfere with sex differentiation of the male during embryogenesis. Human evidence is limited but still concerning. The American Academy of Dermatology notes that human data are limited to a few case reports. 5 cases reported normal male genital development, while 1 case reported ambiguous genitalia after maternal spironolactone exposure through gestational week 5. Because spironolactone can cause menstrual irregularities, it can make it difficult for patients to recognize early pregnancy. Because of the inherent risk for hyperkalemia with aldosterone antagonists, medications that increase potassium such as ACE inhibitors, trimethoprim sulfamethoxazole, and potassium supplements should warrant serum potassium monitoring. The risk for hyperkalemia is higher for patients 65 and older, patients with chronic kidney disease, diabetes, and heart failure. You can pause the video here and review the table if you're interested in the mechanisms by which each drug class increases potassium. The image on the right side of the slide is AI generated. Unfortunately, I don't have access to actual ECG images, but it's good enough to serve as a visual aid for my teaching purposes. Also, the serum potassium ranges below are approximate ranges and not rigid cutoffs. Hyperkalemia creates a progressive change on ECG as serum potassium levels rise. An important caveat regarding ECG findings in regards to hyperkalemia is that they do not reliably correlate with specific potassium levels, and more than half of hyperkalemic patients may have no ECG changes. Also, about 24% of normal kalemic patients can exhibit ECG findings which mimic hyperkalemia. The most predictive ECG findings for serious cardiac events are a prolonged QRS, bradycardia, and a junctional rhythm. For mild hyperkalemia, the classic ECG finding is a narrow-based peaked T wave. For moderate hyperkalemia, the PR interval is prolonged and P wave flattening can occur. For severe hyperkalemia, the QRS widens, P waves may be absent, and bradycardia may be observed. And at very high or pre-terminal levels, a sine wave pattern emerges as the widened QRS and T wave fuse into a smooth, undulating waveform. This rhythm can destabilize into ventricular fibrillation or asystole. Addison disease is diagnosed via a combination of clinical findings, which include morning serum cortisol, plasma ACTH, and confirmation with a concentropin stimulation test, which is considered the diagnostic standard. Concentropin is a synthetic adrenocorticotropic hormone that stimulates the adrenal cortex to produce cortisol. Spironolactone can interfere with some assays and may falsely elevate measured cortisol levels, potentially producing a false negative with concentropin stimulation tests. The FDA label explicitly states that spironolactone should be stopped on the day of concentropin testing to avoid diagnostic inaccuracy. And the answers to the questions at the beginning of the video are 1 Charlie, 2 Charlie, 3 Bravo, 4 Bravo, and 5 Charlie. And that was your dose for medication education. I do hope you enjoyed today's video. If you did, please consider subscribing and sharing my channel. Also, feel free to leave me some feedback. Does somebody out there in my audience know how to pronounce the brand name for the spironolactone suspension? Feel free to chime in. Thank you. Have a good day.